Can I start? गणेश
दुपारी
स्टार्ट
सुरू
करू शकतो?
करूया आपण.
हो हो, गणेशला एकदा विचारते ना.
आहे तू
गणेश जरा 2 मिनिटं थांबूया, बहुतेक तो हे करते. गुड इव्हनिंग मॅम.
गुड इव्हनिंग.
गणेशने थंब दिला की जाधव मॅम चालू करूया.
बरं.
सांग ना त्यांना. मॅडम YouTube लिंक लाईव्ह झाली.
ओके, सो वी कॅन स्टार्ट नाउ ना.
59 जॉईन झालं होतं. 59.
हो हो, याच्यात 59 दिसताय सध्या, पण आता स्टार्ट करूया.
एक्सक्यूज मी, आय नीड टू चेंज द डिव्हाइस.
कनेक्ट कर ना.
लीव्ह करायला लागेल इकडनं.
Okay.
सांगशील का त्यांना?
A good evening to all, and on the behalf of IIC Meerut Sangli branch, I Dr. Rupali, Secretary, welcome you all, and our
Thank you.
today's eminent speakers, Dr. Sandhya Khond ma'am from Pune, Dr. Mohan Patil sir from our branch itself, Sangli, Dr. Kala Ishwaran ma'am. Is ma'am is there?
Yeah.
Kala Ishwaran ma'am?
Yeah.
Yeah, Kala Ishwaran ma'am from Mumbai. I also welcome our dynamic chairpersons, Dr. Usha Badole madam, who was my teacher during my PG from Mumbai, Dr. Sudhir Kadam sir from Meerut, who is a ENT surgeon. I welcome our respected office bearers and our branch office bearers, and all my respected seniors, my colleagues and postgraduates and delegates who have joined this webinar. Now I request our branch president, Dr. Vasudha Jadhav madam, to address about today's webinar and introduce our chairpersons. Over to you, ma'am. Jadhav ma'am.
Am I audible now?
Yes.
Good evening, everyone. Good evening, Sandhya madam, Dr. Mohan Patil sir, Dr. Kala Ishwaran, chairpersons Dr. Usha Badole and Dr. Sudhir Kadam. I welcome you all on behalf of Meerut Sangli ISA branch. I welcome all the delegates and the participants. We all know that giving anesthesia to laryngeal surgery is a difficult and special skill, and it requires a lot of experience, as these procedures include a potential difficulty with airway management, sharing the airway with the surgeon, the effect of pre-op treatment for laryngeal pathology, especially malignancy, and patient comorbidities that predispose to the laryngeal diseases. So now we are going to see how the challenges are faced with the experienced speakers. I've got the opportunity to introduce the eminent chairpersons, Dr. Sudhir Kadam and Dr. Usha Badole. Dr. Sudhir Kadam is a consultant ENT surgeon in Yashashree ENT Hospital and Cochlear Implant Center, Meerut. He has done fellowship in snoring and sleep apnea from Singapore in 2012. He has done mentorship for cochlear implant surgery. He has done foundation course for cochlear implants. He has done fellowship and diploma in lateral skull-based surgery. He is a faculty speaker at various national ENT conferences since 2019, and he has a 9 years teaching experience in Government Medical College. Welcome, Dr. Sudhir Kadam. Dr. Usha Badole madam is professor and head of the department, Grand Medical College, Mumbai, in anesthesia. She has many publications in national and international journals. She is a PG guide to many students. She has 29 years teaching experience. She has presented and chaired sessions in state and national conferences. She has been awarded by governor as a COVID-19 warrior. I welcome you, madam, as well for our today's CME. I think let us proceed with the CME. Yes, Rupali?
Shall I introduce, ma'am?
Yeah,
Yes,
yeah, ma'am.
yes,
Sure.
Yeah.
Yes,
Good
ma'am,
evening,
please
all.
go ahead.
Yeah.
please.
Good evening, all. It's my pleasure to an honor to introduce respected Dr. Sandhya Khond, madam. Madam acquired the diploma in hospital administration. Madam's wealth of knowledge, experience, and dedication to advancing ENT care is 50 years, which she utilized for the guiding and as an examiner for the students of MD, DA, FCPS, and DNB. Madam organized many workshops for anesthesia faculty as well as surgical faculties. It includes tracheal reconstruction surgeries, head and neck operative workshops, interventional cardiology workshops. As we embark on this educational journey, let me embrace the opportunity to learn from the wealth of experience and insights from Dr. Sandhya Khod, madam, on anesthesia for laryngeotracheal surgeries. Madam, over to you. I think madam is there or not?
She had joined long back. I think she must be there. Rupali?
Yes, ma'am. Madam is
Uh,
there. I think she's trying to share her screen.
okay, okay.
Sandhya, ma'am.
नाही होऊन राहिलं. मेल आहे.
Hello, Sandhya, ma'am. I think ma'am is trying something other device. Can we start with the Mohan Patel, sir? Or should we wait? She is not picking my phone.
Rupali, we can start with Mohan Patil, sir. We can start with Mohan Patil, sir, I think.
Madam is waiting so long, na? So just give
Okay,
2
we
more
will wait,
minutes,
ma'am.
ma'am.
Okay, 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 madam.
हा आली. मोबाईल मध्ये आहे ना तुमच्या? तुमचं पीपीटी तुमच्या मोबाईल मध्ये ना? आली थांबा.
रुपाली मॅडमला पर्सनल फोनवर फोन करून बघ ना.
करतायत
हॅलो हॅलो
ते प्रयत्न करतायत.
ओके.
हा मॅडम मॅडमचा नेटवर्क इश्यू आहे त्यामुळे जॉईन व्हायला प्रॉब्लेम होतोय.
बरं.
मग आपण डॉक्टर मोहन पाटील सरांना सुरू करायला सांगूया.
हो
हा
सांगू
मॅडम ते
शकतो.
बघतोय आम्ही. करायला
लेक्चर
लागलोय.
मॅडम.
एक मिनिट.
माझा उषा
बरं बरं.
शी इज जॉइनिंग विदिन 1 minute.
जाधव मॅडम. हॅलो.
बोला डॉक्टर.
मग त्या कलाईश्वर मॅडम करतायत काय?
नाही का तुम्ही
तिथं आमचं पण
टॉपिक वाईज घ्या ना मग.
continue ना.
मग ठीक आहे. हॅलो. गुड इव्हनिंग डॉक्टर
हा
काला.
बोला बोला.
आर यू देअर? डॉक्टर काला.
Yes, madam.
Yeah, good evening. Welcome.
Yeah,
Can you start your session first?
yeah, no issues.
हा दॅट विल बी बेटर मॅडम.
Okay, then we will start with you, madam.
Just 1 second.
Yes, please, please.
आता त्या करतायत. तोपर्यंत आपण
Connect the
आपलं-
microphone.
Okay. रुपाली, तो गणेश आहे त्याला जोडून दे ना जरा.
येस मॅडम बोला ना. हॅलो
हा,
Hello?
डॉक्टर काला ईश्वरन मॅडम कनेक्ट होत आहेत.
अच्छा.
हा.
ह्या मॅडम खोन मॅडम कनेक्ट झालेले आहेत मॅडम.
ओके ओके. मग मी म्यूट
आय थिंक
ठेवते.
शी हॅज स्टार्टेड.
येस.
ठीक आहे, नो इश्यूज.
Anaesthesia laryngotracheal surgeries by Sandhya Khod, madam.
Okay.
Screen is showing that.
Okay. Okay, then we'll wait for her to start.
Yeah, she just joined. नाही 2 मिनिटं बसा ना, जरा बसा ना.
मॅडम ती स्लाइड क्लोज करून परत एकदा शेअर करा.
संध्या मॅम अनम्यूट करा. संध्या खोंड मॅम परत लॉग आउट दिसताय का?
मॅडम आहेत मॅडम आहेत.
नाही, फक्त त्यांचा म्यूट आहे पण अजून पण.
नाही हे होईना सुरू पुढे.
हॅलो मॅडम, मॅडमचं कनेक्ट होत नाही का? ते
नाही,
स्लाइड
ते
पुढे
slide
जात
पुढे
नाही.
जात नाही.
Slide पुढे जात नाही. ते unmute करायला पाहिजे. Unmute.
हॅलो मॅडम, आवाज येतोय का माझा? हॅलो
हो, तुमचा आवाज येतोय.
मॅडम, ते पीपीटी एकदा क्लोज करा आणि ज्या अदर विंडो आहेत त्या पण क्लोज करा आणि एकदा परत पीपीटी ओपन करून मग शेअर करा.
Top up करते कसे? ते कधी?
हे मॅडम पण सुरू करूया आपण तोपर्यंत.
WhatsApp वर लगेच. तुमचं बोलतो.
हॅलो मॅडम, इट्स विजिबल. हॅलो
जस्ट टॉक विथ द संध्या मॅम. ते लिव्ह करून परत एकदा जॉईन करायचा प्रयत्न करताय. We give her 2 minutes. Otherwise, we can start with Kala Ishwaran ma'am.
Hello. Hello, can you see me and can you hear me now?
Yes, ma'am. I can see
Okay.
you and I can hear you.
Okay. What about others? Everyone can see me and Ganesh is sharing my screen. Am I right, Ganesh? Okay, I can.
Yes, madam. Yes, yes.
Okay, I can start on my own now.
Yes, ma'am.
Okay. First place, sorry for the delay. I'm wishing you a very, very good evening from me. As a ma'am has already said, these are all high-risk surgical procedures and too many challenges. But before that, let me make very clear that there are many surgical procedures, not less than 110, to begin with the simplest scopies to complete resection and lower down till the cranial level. So the challenges are to find the airway. Where is the airway? You have to find it and you have to share it with the surgeon and protect the distal airway. And yet at the end, you want the patients to be awake. To make it safe, let's go into the salient features of the history. Again, the number matters. Not more than 40 signs and symptoms could be elicited. The patients usually will have dyspnea at rest, which indicates 75% reduction in the tracheal diameter, a stridor, which could be biphasic, inspiratory, or expiratory, depending on the location. Patients are smokers, and their malignancies and severe COPDs, and the effects vary. They have dysphagia and odynophagia. But most important is for us to find out the position in which the patient breathes comfortably. And in polytrauma, the laryngotracheal injuries, the cervical spine injuries with the neurological deficit is a separate chapter by itself. The message is that there are a wide variety of signs and symptoms, and unfortunately, they do not always keep with the severity of the lesion. But despite the airway narrowing, your patient may not be at distress at rest because the patient is now getting adapted to the narrowed new airway. These patients are radiated and the patients will have laryngeal edema, which is shown by the murmuring. What matters is the radiation pneumonitis and pneumonia, which may be asymptomatic, which is a catch point. These patients are anemic, volume depleted with erythema and edema all over. But again, point of importance to us is the contractures, fibrotic contractures, which cannot be relieved by the neuromuscular blockers. What can take us by surprise is the baroreceptor dysfunction. Our patients may not be symptomatic for orthostatic hypotension. They are asymptomatic. So unless you know it, the patient knows, this can create a waste massacre. So working of these patients from all possible angles is equally important. Gold standard, of course, is pan endoscopy. Try to understand the other side. The global visualization of the laryngeal, pharyngeal, and paraepiglottic structures may not be possible because the tip, however good and degree angle is available, the complex anatomy of larynx, like subglottic, ventricles, commissures, folds, all areas may not be available. Direct laryngoscopy is invasive, yes, but again we are viewing only the lumen. No transmural evaluation or information can be obtained. And that's exactly why computer-generated three-dimensional
You tell-
reconstruction. Yes, please. Can you hear?
Yeah. When to
Slides are not visible.
when to move on? Karan, slides are not getting connected with
Slides
your.
Can you now?
No, it's not visible.
Ma'am, you Ganesh when to move to next slide so that he can share the next slide.
Okay. So computer-generated
Now it's on.
visual
He is on
laryngoscopy.
history.
Ganesh, can you see this slide? Working of previous one. Ganesh, can you see?
Which
The computer-generated three-dimensional reconstruction of the CT image is very important. Sometimes the lesions are very small, low resolution, and they have to be picked up. All the smallest possible lesions. Can you see
Slides are
now?
not visible, madam.
Okay. The Ganesh has to help me out
Yeah.
because he's sharing the screen. Ganesh, can you go to this slide?
I suggest please let madam talk. It sounds very good without slides also. Please continue, madam.
No, slides.
No, but I
Has
wanted
to
to
be
show
there on the screen.
Okay. So
अक्का आता कनेक्शन रेंज ये मिले ना हाँ
okay.
हो
So what do I
Either
do?
video or not slides.
Do I go ahead without slides?
Please, madam. Definitely, madam.
Okay.
It is really interesting subject. So no slides are required.
Hello.
Okay,
Please
now
continue,
this
madam.
हॉटेल मध्ये
yeah, the computer generated three-dimensional reconstruction
घरी करणार
of
करा की अक्का
yes.
Now
I
you
can
are on
see.
right track.
So the small growth
Please
and the
make
lesion,
unmute to all.
the smallest possible lesions with the lowest resolution is possible with this. Next, please. Ganesh, next, please. Can we relate it to the spirometry? Because FEV1, FEC and other things, the volumes, capacities may not relate. So flow volume loop abnormality is the one parameter which is going to detect any abnormality, which can let us do a CT scan and diagnose it. But remember, tracheal larynx has to go down to less than 8 millimeters before even the flow volume loops can pick up the lesion. So it is a peak expiratory flows, which is the most sensitive parameter to diagnose the middle airway and small airway disease. We are not only interested in upper airway because the gas flow and the gas exchange is equally important. And I insist, that a CT scan with a dynamic study to pick up, not only quantify the lesion, but is equally important for us to know the surrounding structures. Word of caution. Next one. Ganesh, next, please. CT done before the procedure, a few weeks before, 10 days, may not reflect what the picture is today, because you may be dealing with fast-growing malignancies. In that case, a fresh proboscopy or panendoscopy within 8 hours of surgery, next please, is mandatory. Now, this is what is shown with the Mayer cotton grading. There are many 6 or 7 types. My surgical colleague would be able to throw more light on this. But grade 1 is up to 50% obstruction. This is how it will look on the endoscopy. Grade 2 will have about 50-70% obstruction, and the lumen will be seen like grade 3 will have 70 to 99%, and the airway is reduced to a small chink. Next, please. Now, this is a CT scan, a dynamic CT, which I was talking about, is a star case that we have done. This is a corneal and sagittal plane CT. What it shows is the para and periepiglottic extension and invasion of the lesion. That's not all. Patients are absolutely asymptomatic, number 1. Number 2, all your routine tests to diagnose difficult airway. How many are there? 40, 45 names are there. None of them would pick up these because patients are not clinical. And no measurements are going to give you this. And that is exactly why a dynamic CT plays a very, very good role. Another friend in need is ultrasound. You can see all the applications, but I will give good marks to USG for giving me a DLT size. We are not dealing with a normal airway. So normal, okay, I will use 41 DLT. No, I cannot, because this is a narrowed, distorted, obstructed, twisted airway. Next, please. So, next, please. So this is a USG health. Now, patient selection. I'm not saying that there are any contraindications. Of course, these are all life-saving surgical procedures. But patients who have severe COPD, neuromuscular dysfunction, who are dependent on massive doses of steroid, uncontrolled hypertensives, diabetics, and ischemic heart disease, redo surgery, and very long tracheal lesions of more than 5 to 6 centimeters. We operate them, but they go back on ventilator dependence and they don't behave well. So all the efforts may become futile. Next, please. And exactly that's why a good planning of surgery and anesthesia to suit an individual patient is important. It must be discussed with all the team members. And the exact duration of loss of airway control. That means there's no airway at all. That duration must be known to each and every member. See, there are ideal plans for plan A, B, and C changeover, but this should not only be decided, but this change should be automatic and algorithmic. In no other branch of anesthesia will this insistence on automatic algorithm change is. And not only that, with bringing the patient or inducing the patient on the pre-op room also is not advocated. So you have to have a ready to go with all the alternative plans and then induce only on OT table with the surgeon scrub and all plans ready. These are the things. Please change the slide. Keep ready all the MLTs, fiber optics, and all that. Now, you can get better results if you nebulize these patients, atomize these patients, humidify these patients, give beta agonists, anti-cyanogogue. They will have a temporary stabilization and opening up of the airway, which is most important. Patients do have PONV. So PONV prophylaxis plays a major role in upper airway surgery. Now, direct laryngoscopy response. Stress response to laryngoscopy is something, it's a noxious stimulus, and we have been talking for last 4 or 5 decades, but there we're talking only of a scopy lasting for 25, 30 seconds. Now here you're dealing with a scenario where the larynx will be handled for 1 hour, 2 hours, or maybe more. So a definite plan to attenuate the stress response must be worked up. Whatever is your choice, whatever suits the patient, but it should be ready. Usual 3 minutes pre-oxygenation may not be adequate because you want to denitrogenate and airway is not normal. And I'm afraid you'll have to take a longer time to pre-oxygenate these patients. There is a definite role, change please, there is a definite role for pre-operative CPAP to give you, change please. Now, the plan for anesthesia usually will depend on the tracheal diameter. Diameter more than 8 millimeters. We could go ahead with a standard small size intravenous induction, ETT or supraglottic airways, and then proceed with the open airway management. But if the tracheal diameter is between 5 and 8 millimeters, it is advisable to go ahead with the fiber optic inhaled induction with the increasing concentration slowly with watch, and then go to ETT ACT. But if the diameter is less than 5, then the definite role of awake fiber optic intubation, spray as you go, SAGO technique, topicalization of the airway, dilatation, and then small size tubes, and then manage the open airway. Change, please. Airway management will have either intubation and tubeless techniques. When you talk of anesthesia for these procedures, everything is centered only on airway and airway management. Change, please. Intubation change, please. There is a microlaryngeal tubes. MLT will have about a diameter change, please, Ganesh. 4 to 5.5 millimeters, 30 centimeters long. Change the slide, please. Can I have the next slide? And this is lying between the arytenoids, 4.55 millimeters, 30 centimeters long, high volume, low pressure cuff. And this is again a star case, but anterior 2/3 of the glottic opening is visible because they lie closer to arytenoid. And here is another case as against this, the right side, you can see a jet 4F or 6 French, which is giving, making my surgeon very happy because I could give almost 90% of the glottic. Change, please. Change, please. This is a tri-tube with a triple lumen, with a ventilation lumen, a pressure measurement, and a cuff lumen. Pressure measurement can also be connected to an ETCO2 monitor, which is an added advantage. This is ultra thin, does offer a lot of resistance, and inflatable high volume low pressure cuff with a mercury's eye. Change, please. Change. This is a LITA, as all of us have used this. This is a portal for injecting local analgesic solution, lignocaine, with 3 or 4 points. Change, please. Change. This is a spray ports, and you can maintain good depth of anesthesia by continuous spraying. Change, please. Could I have the next slide? You can also use lignocaine within the cuff. Okay, hygroscopic lignocaine to inflate the cuff rather than air. Okay, and the gradual migration up to 2/3 of the drug. It provides a continuous seepage and change, please, better hemodynamics all through the surgical procedure. This is how we ventilate the patients with an endotracheal tubes. This is one tube rigid staying above the lesion, and till such time the trachea is resected. After tracheal resection, a flexometallic tube is put into the distal trachea, and the segment is resected. Posterior anastomosis is done with the distal ventilation. After it is done, distal tube, flexometallic tube is withdrawn, and this proximal tube will be pushed back, but the tip to be above the carina, and then finish the anterolateral anastomosis overview. Cross-field ventilation, one of the basic principles, very simple and easy to perform. Does not need any extra devices on. But if the resection or the lesion involving lower trachea, carina, or bronchi, a sleeve resection of bronchi, then probably I cannot practice it. So it's a one lung ventilation with an endobronchial tube with probably change, please. Going to maybe requiring the This is what is cross-field ventilation. This is a clinical picture marked for you. This sterile circuit, 2 sets of sterile tubes, 2 sets of sterile circuits are the only thing that is required going into the distal area. Proximal area is hidden under the drapes. But this is a very simple technique. Change, please. Change, please. An endobronchial device also can be used. It's a simple device, a suction cannula, 3 millimeter diameter, connected to a ventilator, threaded through endotracheal tube of normal size. Tube stays up. Only the suction catheter goes in the bronchus, one of the bronchus. It maintains good saturation and allows the ventilation and unobstructed surgical view. That is what is required. Okay, change, please. This is a Montgomery T-tube with a T. This comes out through the skin, as you can see. This is the proximal vertical limb. This is the distal vertical limb, which goes into the lower trachea. The advantages are many over tracheostomy. It connects with the glottic opening, so phonation and communication is possible. Change, please. We have done many cases with successfully with Montgomery. Supraglottic. Today there is one question mark. 3 decades back, I would have put five or 6 more question marks. Intraoral, airway surgery, and supraglottic, not to be considered. Today, the trend is such, and with the introduction of second generation supraglottic, we have made this very, very safe till such time the surgeon intrudes into the bronchoscope or the airway, and it provides acceptable levels of airway pressure, oxygen, and carbon dioxide. The plus point, best plus point is it mitigates the stress on anastomosis. You're staying away from the airway, so anastomosis is 100% effective, possible, very easy, and get enough time. You can use the same SAD, pass through the FOB, through the SAD, and visualize how the anastomosis has been done. You can assess it. Same SAD can be kept postoperatively. Change, please. You can deliver CPAP in the postoperative period. Popular is tubeless. Tubeless can be without tubes. These are becoming very, very popular and demanding conduct of anesthesia. Low flow, about 1 liter per minute. CO2 rise is in the region of 3 millimeters of mercury during the period of apnea. While high flow nasal oxygen begin at 30 liters, but can be maintained around 70 liters per minute. Capnography is not possible with apneic ventilation, so transcutaneous carbon dioxide monitoring was something that we undertook. Patients don't saturate for up to 1 hour, 1.5 hours period, and the rate of rise with high flow is only 1 to 1.5 millimeters of mercury per minute for the period of apnea. Physics is very simple. 250 ml of oxygen is washed out of the alveoli. Only 8 ml of carbon dioxide will be added. How much is the gradient? 220, 230 ml. Now, this creates a large negative pressure in the alveoli, which sucks in large amount of air from the upper airway, upper trachea. This is a ventilatory mass flow, which maintains the oxygen. And very low creep of 2 to 2.5. Change, please. Is possible. Change, please. Now, this is airway exchange catheter. Now, if I have successfully intubated a patient that has a difficult airway and the tube is coming in the surgical procedure, I cannot say no, it has to come out. Anyone would be too skeptical to get rid of that tube. So here is another thread in need, airway exchange catheter, which is marked up to 40-45 centimeters approximately. You can thread the catheter through the tube, let the AEC be there, remove the tube, and when change, please, and ventilate with the jet. So this is a good friend of ours. Jet, change, please. Change the sling. Okay. So this jet equipment is another tubeless. You stay away from it using gas flow between 15 liters per minute and less than 50 psi. Injector needles about 12, 14 gauge for adult, 16, 18, 20 for pediatric. Change, please. Change, please. Change. So adults, you start the jet pressure around 20 psi and go up to 45. But in children, you begin with 5 to 10 psi and stay below 25 psi with an IE ratio of 1:3, which is remarkable. Remarkable. 1:3 or 1:4 even. I have to adjust inspiratory time, IE ratio, the frequency, and the driving pressure. We can use supraglottic, subglottic, or transtrachea. But when I'm putting the jet cath distal to the lesion, then there is a change please. Then there is a danger of air trapping, barotrauma, and autopsy. Why? Because the problem with jet is not much during inspiration, but during expiration. Change please, because of the inefficient, inadequate movement. Now, if the frequency is high, there would be a hindrance, as I said, to the deflation. Lungs cannot empty themselves, and that's why there is a strong positive peripheral airway pressure which keeps on building. If I'm using transglottic change, then I better use a double channel tube, which is giving me an idea about the distal airway pressure, as well as I can monitor the end-tidal CO2. Change, please. Change. Change, please. Yeah. Now, how does the gas exchange occur? With high frequency jet ventilation, the tidal volumes are even smaller than the dead space. It's very important. So respiration is never physiological. That the jet stream will pass through the airway in a laminar flow, and the flow and velocity in the center is moving in a faster way as compared to the wall, along the wall. This is called a parabolic configuration. It creates a parabol, and that is essential and necessary to allow the jet to flow across. Change, please. Now, molecular diffusion, a Taylor type of dispersion because of this gradient difference. Lot of difference between the central airway pressure, that is in the center of the airway, and along the bronchial valves. But the regional variations in airway resistance and compliance can cause some areas of the lung to fill empty inadequately. And there's bound to be a lot of rebreathing and progressive increase. Change, please. Change the slide. Now, to obviate this, what we have is a low and high frequency put together in a superimposed jet ventilation. Low will have 8 to 20 and high will have a frequency between 100 and 200. They come together, they're welded together. This is the distal, they're put together separately, but in one lumen. The high frequency injector is distal, so it can entrain a lot of air, and the two different sources will meet the required tidal volumes. So my problem was of low tidal volumes, lesser than dead space, that is obviated. Another thing is that they don't intrude into the lumen. So the laminar flow is maintained without offering change, please, without offering any resistance. Change, please. Change. Change. Of course, the modern jets, they offer a lot of humidification, and a specific feature that they have is a pause pressure, which limits the air trapping. And they assist the egress. Now, what is egress? Egress is a simple process by which exiting, that going out of the tidal volume by having a negative pressure, that is providing suction along the walls. That assists the exhalation process. So my problem is that conventional jet is obviated. So I can have a better gas mixing, good expiratory flow, and also they have all possible monitors and alarms and automatic cut devices. So cutoff device will limit the pressure being built up in the expiratory. Change, please. Change. Thrive is another popular technique of apneic ventilation, non-obstructive surgical field, and it maintains the oxygenation for up to half an hour or even 45 minutes. And increase in CO2 is only in the region of change, please, only in the region of 1 millimeter to meter. Now, this is what is Thrive that is being used. And you can see the cannula delivering high flow humidified oxygen, high FiO2. So it maintains, and endoscopy, suspension endoscopy is in change, please, change. is in progress. But for the lesions involving, as I said, carina, bronchi, sleeve resections, can I use these techniques? No. Obviously, I would need either cardiopulmonary bypass or veno-venous or veno-arterial ECMO. Now, patients who are, especially pediatric age groups, they cannot withstand long procedures and hypoxemia and hypercarbia. So over there, change please. So extracorporeal circulation is something that change please. So Heliox did enjoy good popularity. Physics-wise, yes, because it lowers the density, which increases the laminar flow, it reduces the Reynolds number. Physics, yes, very good. But physiology, no, because FiO2 could be low. Change, please. So patient could turn hypoxemia. Change, please. Neuromuscular block. Now, what we are monitoring usually with an adductor policies, but the catch is the laryngeal, external, internal laryngeal muscles, they recover much, much faster than APM. Now, where is the need? There is a question mark. Contrary to the belief, a deep neuromuscular block is required because few surgeries are done under microscope, very fine surgeries, very fine anastomosis in a small child. Okay, and few millimeters, fraction of a millimeter here and there with the tone in the muscle is going to jeopardize and undo all the futile. And that's exactly why a deep block change, please. Deep neuromuscular block is required. Same thing true about the stress. Now, where is the pain? Again, still one can argue that they're dealing with very tiny structures, but they are richly innervated with 3 sets of nerves with 7 and 8 branches, richly innervated. So, pain by retraction, pull, push, packs, and this is likely to induce not only the stress response, but arrhythmias, which are probably difficult to treat. Change, please. So, good amount of depth is required. Total intravenous forms the mainstay of laryngotracheal surgeries because it offers consistent anesthesia delivery, and the major benefit being that you are staying away from the surgical field and yet provide excellent condition. It has to be titrated, but I think with the recent modern technological innovations and beautiful infusion pumps, it may not be difficult with BIS monitoring. On the other side, inhaled agents, they show tendency, change please. They show a tendency to collapse their way and the control will be very difficult. It's not like a tire control with inhalation and certification. Intraoperatively, apart from oxygenation, I will also be worried about carbon dioxide and acidosis, which can lead serious arrhythmia. Lower airway, vagal innervation, bradyarrhythmias, and arrest. Now, change in the tracheal diameter. A positive intrathoracic pressure with IPPV in very high pressure can cause inward projection. The airway is supported by cartilages, but posterior lateral part is not supported. So it's membranous, so it can fall back and cause decrease in the lumen. That would be detrimental. Similarly, we contribute a lot in deciding the tracheal length, which is excised, and accordingly, the flexion and extension to mobilize the tracheum to make it cervical and cervical to mediastinal blank. And you have to have a good synchronization and choreograph with the surgeon to decide the degree of flexion that would be ideal to expose the liquid. Now, with the terminal lesion, yes, cross-field ventilation, but then it's practically very difficult to put the tube in at the carina, above the carina, and let it not go into the bronchus to cause hypoxemia. That is very tricky and very irritating. Change, please. Change. Change, please. Post-operatively, what you need is a very smooth emergence from there. No bucking, no coughing, no sickness, and no vomiting, retching. These patients should be electively nebulized with automizers, humidification, bronchodilators. The neck is flexed for almost 6 to 7 days. You should be watching for stridor wheezing, obviously, but I would request that you please share the responsibility of residual anesthesia effects for first 8 hours, which is mandatory because the elimination of the anesthetic agents is also not physiological. So you must share the responsibility. Role of elective CPAP to open up the airway. They not only act on lower airway, but the oropharynx, the soft tissues, the palate, the base tongue, everything opens up. The lumen improves. The laminar flow improves. Resistance goes down. Work of breathing goes down. So there is no doubt that CPAP plays a good role. Patients who are hypertensive, they may develop small hematomas which are enough to cause airway obstruction. So control of blood pressure in the perioperative period is one of your domain, and you should see to it that very rarely, but mediastinal injuries, emphysema, change please is something that cannot be helped. Change please. Change please. Please change the slide. Change please. Yeah. Thank you. A word about the synchronous airway lesions. The patient has a dominant airway lesion. This is limiting the airflow distally. Even if there is a lesion, it is in disguise. You don't know about it. The dynamic lesions are appreciated only when the air will flow across that second lesion. If there is no flow, dynamic lesion will not be appreciated or will not know about it. Now what you have operated? You have opened up the air. You have cleared the lesion. Now, lot of air and oxygen will flow across the second dynamic lesion, which is a simple Bernoulli's effect. And that's why, unfortunately, the presentation of these Bernoulli's and airway collapse with stridor will be manifested to you only at the end when extubation. Now, and that's exactly why I was insisting on picking up small resolution growth on dynamic CT again and again. Change, please. So this is about the synchronous airway lesions. Change, please. Change. Now, tetraplegia is another complication that has to be watched. Now, why tetraplegia? Because of the position that is required so that no tension on the suture line after the lesions are hyperflexion of them. Now, change, please. Change. Now, this is how the patients will be nursed in the postoperative period with the guardian roll suture, and more than 25 to 30 degrees acute flexion may be required to keep the trachea lax and not under tension. Now, this is something that may cause tetraplegia. It's not rare, mind you, it's not rare. It may not be common, but it is found, and 85 cases have been reported in the literature. And after that, we have been very careful to limit the flexion in the postoperative period. The second case, you can see the nasopharyngeal airway is put as a safety device. Change, please. Change, please. Thank you. Thank you very much. Thank you for letting me share my views. Thank you, ISA Mirrors Sangli branch. And thank you, my colleagues who helped me unconditionally. Thanks a lot. Thank you so much.
Thank you very much, madam, for excellent lecture. It was very informative. Everybody gained from it.
Yeah, thank you.
A wonderful presentation, ma'am. It's very explanatory. Can we start with the Kalashwaran, ma'am?
Kalashwaran
Or
or Mohan Patil sir, second speaker.
Sir, we are trying to connect his PPT, but it takes time. So it's better we start with the Kalashwaran, ma'am.
Okay. Shall I introduce her?
Okay. Ganesh, please share Kalashwaran, ma'am, slide, CV slide.
Yeah. Let me introduce versatile Dr. Kala Ishwaran, who is a freelancer consultant anesthesiologist in Dombivli Kalyan area. Kala madam Kala madam's special interest is regional anesthesia, difficult airway, and safe anesthesia practices at nursing home. She has her YouTube channel, teaching channel, and a special Facebook airway page. She has authored a pocket book on regional anesthesia, which is available in Amazon. Madam conducts a hands-on workshop on regional and difficult airway. She attended various national and international conferences as faculty, and in 2017, anesthesia, regional anesthesia presentation in Newark Society of Regional Anesthesia. Madam has numerous national and international publications. All her achievements gives her various awards from different organizations such as ISACON in 2017, GARC in 2017, and IMA Dombivli in 2023-24. With academics, Madam excel in Bharatnatyam and contemporary folk. Madam will deliver lecture on the topic blocks for head, face and neck surgeries. Kala Ishwaran, Madam, over to you.
Am I audible?
Yes, you are.
Yeah, my screen is seen.
Yes, ma'am. Your screen is visible.
Yeah, thank you, Meeraj Sangli, for this invite. And I thank all my surgeons and patients for their continuous cooperation, without which this isn't possible. There are no disclosures, image and video credits to Google, Internet, Nysora, and my operation theater staff. This is a photo and video consent form which we take from all the patients for educative purposes when we shoot and record. Now, coming to head, face, neck surgeries, which we generally routinely do, the neck surgeries like thyroid. This is a huge thyroid, which this patient was deferred for by almost 6 years not getting operated. And once we decided upon block, she was called from her hometown. These radical neck dissections, parotid gland, and cancer tongue lesions. All these are the ideal anesthesia technique is general anesthesia with endotracheal intubation with or without muscle relaxants. So how do we go about with the blocks for these cases? Blocks of head, face, neck. The neck supply is from the cervical plexus block, deep cervical plexus blocks, and the superficial cervical plexus. The face blocks include the trigeminal and its branches blocks and skull blocks. Now, right from the MBBS days, it was very difficult to remember and memorize all the, so I may just simplify according to the case because still it is very difficult for me. Cervical plexus is formed by a conglomeration of cervical nerves formed from the anterior rami of the spinal nerve C1 to C4, giving both the muscular and the superficial sensory branches. The anterior ramus of the C5 goes to form the phrenic nerve. That is very important for us. Superficial branches, okay, of the cervical plexus coming out behind the lateral border of the sternocleidomastoid muscle at its midpoint gives out the superficial branches. They are in the mnemonic that is GLAST, G-L-A-S-T. That is greater auricular, the lesser occipital. Okay. Then A is accessory branch. Then S is for the supraclavicular and T for transverse cervical nerve. Innervating laterally from the lateral pinna, behind it, along the mastoid, the lower jaw, up to the clavicle, till the midline, then the clavicle, and the upper shoulder. That is the anterolateral part of the neck. And therefore, the indications for this block includes any surgery in this area, that is lymph node biopsy, thyroglossal cyst, brachial cyst, vascular excess, IGV cannulations, radical neck dissections, mastoid, and all. This is a transverse section showing where we the needle tip lies in a superficial cervical plexus block, the intermediate cervical plexus block, and the deep cervical plexus. So you can see just above the superficial cervical plexus, just beneath the skin and subacute over the sternocleidomastoid. By piercing the investing fascia of the neck, that is this one, just beneath the behind the sternocleidomastoid, you get a small pop, that is for the intermediate cervical plexus block. And for the deep cervical plexus block, you have to pierce the deep cervical fascia to reach the cervical roots here. No, you can see that it is very close to the spinal cord, the vertebral artery, and the epidural space. Now, coming to the superficial cervical plexus, you are blocking these 5 nerves, that is the greater auricular, lesser occipital, the accessory cervical, the supraclavicular, and the transverse cervical. You hit the point of needle entry is at the midpoint of the lateral border of the sternocleidomastoid muscle. Now, you can see the sternocleidomastoid muscle, the sternal head, the clavicle head. You can see the EJV, that is external jugular vein, is also crossing around that point. So to avoid that, you can go few millimeters above the EJV at the lateral. So this is an injection video. You feel for the sternocleidomastoid muscle. You can see the external jugular at the midpoint. That's the midpoint from mastoid to the sternal head. Just beneath the skin subacute at the posterior lateral border of the sternocleidomastoid. So you can see how the injection is displacing the EJV. I'm slowly bending the needle to prevent inadvertent deeper puncture because you have vascular structures beneath. And in a fan-shaped direction, you will be injecting all along the lateral border. Okay, this is the intermediate cervical plexus. You can see the pop of the intermediate investing layer of the fascia, cervical fascia. That is the intermediate cervical plexus block. Now, coming to the deep cervical plexus, you have to go deeper to the deep cervical fascia. It blocks the phrenic nerve. That is very, hence you should avoid a bilateral block. The landmarks here includes the mastoid process, the Chasna's tubercle at the cricoid cartilage, that is the transverse process of the C6 vertebral body, okay, and along the posterior border of your sternocleidomastoid. What you do is feel for the mastoid process, the caudal-most point, and the C6 transverse process, okay, and at regular intervals, you will feel at 2 centimeters distance, you will feel C2, C3, C4, C5, and C6. You have to hit the transverse process, withdraw few millimeters, and inject around 3 to 4 ml of the local anesthesia solution at each level. Okay, even a single injection at C3 is enough. Okay, you palpate the transverse process, and in between you enter with the needle perpendicular. Now the depth, the transverse process is contacted at around 1 to 2 centimeters almost in all the patients. Never go beyond 2.5 centimeters because there is risk of spinal cord injury. Paresthesia may be elicited, but it is unreliable. Major indication for a deep cervical plexus block is carotid endarterectomy. Now, the contraindication for deep cervical plexus block is giving it bilateral because definitely there is phrenic nerve paralysis. So, if the patient has significant pulmonary diseases or if the contralateral phrenic palsy, nerve palsy is there, please avoid giving deep cervical plexus block, and this is a high risk deep block with potential complications. Now, this was a publication where we had published a series of thyroid surgeries done under bilateral superficial cervical plexus block. And so you bend this, it's a simple hypodermic needle, feel for the belly of the sternocleidomastoid, the lateral border, and this is a superficial cervical plexus, giving in fan-shaped direction all along. You have to remember that the anterior neck is the transverse cervical, okay? Then the investing layer of the cervical fascia and inject 5 ml beyond the investing layer of the fascia for the intermediate cervical plexus and at the superficial. You can give either of the one also, because finally you're blocking the superficial nerves of the cervical plexus. Okay. Here I'm giving both 5 ml at the superficial level and 5 ml at the intermediate level. Okay. You can see the distinct pop of the investing layer of the cervical fascia. This is along the sternal border. You infiltrate when because the nerves from the chest is also overlapping here. This is an intraoperative video where the patient, everything is bad and the patient could talk to us, swallow and show, no? Okay. And this is a post-operative video. Immediately you can see the patient is, you keep the sedation scores of around 1 to 2 where the patient is aroused. Now this 88-year-old COPD patient had come for bilateral neck dissection. She had severe respiratory disease and she was declared as respiratory arrest in the previous induction. So we gave her bilateral superficial cervical plexus block, and wonderfully the surgery was done. And you can see this 88-year-old lady is cooperating while the end of the surgery. I recorded this video. Now the surgeons got more greedy. They started asking, you're doing radical neck dissection, thyroid. Now this parotidectomy patient has come with severe cardiac disease. Okay, so again, now coming to the pinna of the ear is innervated by the trigeminal nerve and the cervical plexus. Okay, the superior 2/3 of the anterior surface by the auriculotemporal nerve of the mandibular division, and after that the auriculotemporal gives supply to the parotid gland also. Okay, and the posterior surface of the ear and the lower third of the anterior surface is supplied by the greater auricular and the lesser occipital branches from the superficial cervical plexus. Okay, now the greater auricular supplies the fascia over the parotid gland, and the parotid gland itself is supplied by the auriculotemporal. Okay, and at the tragus you have the auricular branch of the vagus nerve also. Okay, so this patient had global hyperkinesia. So parotid gland, the auriculotemporal nerve block was given 5 ml anterior to the tragus. Okay, with simple hypodermic needle, 5 ml of the LA solution, and the fascia over the parotid gland is greater auricular and the pinnae behind is lesser occipital. So I gave a superficial cervical plexus block 5 ml. The incision, that is the mandibular area, they were thinking of extending it. No? So I gave a mandibular nerve block, which also, this will be enough to cover the auriculotemporal also. But still I gave mandibular nerve block around 5 ml of the LA mixture. The LA mixture used was 2% adrenaline xylocaine along with 0.75% ropivacaine. And after giving, the surgeon told he might extend it further ahead. So we give a 3 ml of zygomaticotemporal nerve block at the lateral part of your canthus, that I will come when I'm talking about the skull block. Now the mandibular nerve block, what all nerves it covers is almost the auriculotemporal, by the posterior division, the inferior dental, nerve to the mylohyoid, genioglossus, hypoglossus. The posterior division ends as the mental nerve. Also gives a lingual nerve, and all the styloglossus, genioglossus, and hypoglossus muscle. The anterior division is the deep temporal branch and the anterior deep branch. So in short, instead of remembering all that, you remember that the ipsilateral mandible, the teeth, the buccal, and the lingual hard and soft tissues, and anterior 2/3 of the tongue and the floor of the mouth is supplied by the mandibular nerve. So what are the bony landmarks? Is a zygomatic arch, the mandibular notch. When you open and close the mouth in front of the tragus, you will feel the mandibular notch. Okay, so that is where we are entering. Okay, and you can feel the anterior and the posterior border of the mandible. With a simple hypodermic needle, around 5 ml of LA solution is enough. The depth to maintain around 2 to 2.5 centimeters. Okay, this is a PNS guided mandibular nerve block. You will see that there is, by entering at the notch, mandibular notch, hardly, this is a 5 centimeter needle, hardly around 2 centimeters, not even 2 centimeters, and you're getting the block. Okay. Now, this is the post-operative video where we can elicit any facial nerve damage or something. The patient is asked to clench the teeth. She is easily following. The Ramsay sedation score is maintained at around 1 to 2. Now, coming to a CA tongue with radical neck dissection. This was a 92-year-old mother of a doctor, hypertensive and diabetic mellitus, age-related ECG changes. They did not want much of intervention. This was the lesion, tongue lesion was very small. Okay, so we did this under superficial cervical plexus. Now, coming to the innervation of tongue, the posterior 1/3 is supplied by the glossopharyngeal nerve, which is the sensory and for the taste. The anterior 2/3 is the lingual branch of the V3 that is the mandibular branch. Okay, anterior from the trigeminal, and the taste is supplied by the tympanic branch of the facial nerve. Okay, now this lesion was in the anterior 2/3. Okay. So what we did is I gave glossopharyngeal nerve block at the tonsillar pillar base. Why? Because to avoid the gag reflexes, which will come along with the pulling of the tongue and putting in a tongue depressor while doing the surgery. Though per se the lesion was in the anterior, and in the midline, I could have given a mandibular nerve block. Okay, for the lingual nerve and or local anesthesia gargles but then we infiltrated 3 ml at the midline, so it gave a infiltration block. The superficial cervical plexus 6 ml and intermediate cervical plexus 5 ml. Used an LA mixture of 2% adrenaline xylocaine with 0.75% ropivacaine. Sedation was just 1 milligram midazolam and 1 gram paracetamol. Now, glossopharyngeal nerve block, where do we give is the at the anterior tonsillar pillar at the base. This is the posterior part of the tongue depressor, and this is where you give the glossopharyngeal nerve block. Now, this is the intra-op. They use the laser and constant suctioning. Okay, the patient was awake, was given oxygen throughout using nasal prongs. Okay, very cooperative patient. And post-operatively, you can see this patient was wide awake. She could open the mouth, respond to our commands. Okay. Now, the same thing around COVID time, I did many cases and had publication also. Now, further, the superficial cervical plexus block was also used for laryngectomy, wherein we put in the tracheostomy under the block and then followed by GA for the laryngectomy. You can see excellent field, because of the nerve block. Now, this patient came with a thyroid cancer with cranial metastasis. You can see a huge thyroid and a huge cranial bulge of the metastatic. So a metastatic thyroid cancer, she had convulsions with cranial mets, lung mets, spinal mets, had undergone radiotherapy, and the coagulation profile was normal. So we gave a superficial cervical plexus block along with the scalp block. Okay. So total 20 ml of LA was used, a mixture of 2% adrenaline xylocaine and 0.75% ropivacaine. No sedation was given, only 1 gram of paracetamol with 20 mics of dextromid. Now, this is the cranial lesion. Now, scalp block involves scalp is supplied by 7 nerves, 4 from the branches of trigeminal nerve and 3 branches from the cervical nerve roots. So the 4, that is anteriorly, it is by the trigeminal nerve, that is the supraorbital, supratrochlear, the zygomaticotemporal, the auriculotemporal nerve lies behind the temporal artery. Okay, these are the 4 for the trigeminal nerve, and posteriorly, posterior scalp is supplied by the greater occipital, in front of which lies the occipital artery, the lesser occipital, and the greater auric. Okay, so these are the landmarks also. That is, you feel for the supraorbital foramen here. Okay, and there you infiltrate 3 ml of LA for supraorbital and supratrochlear. So this is the video where I'm showing the scalp block using just a simple hypodermic needle, 5 cc syringe and 3 ml of LA solution at each point. This is the felt for the supraorbital foramen at the medial side of your eyebrow, and made a nice wheel. It will cover both the supraorbital and the supratrochlear. At the lateral side of your canthus, that is the eyebrow, is your zygomaticotemporal. Okay, again 3 ml of LA is infiltrated. It's a subcutaneous injection. Here you have to feel, aspirate and feel for the temporal artery. Now posteriorly, you feel for the mastoid process and the occipital protuberance. Draw a straight line and divide it into 3 parts. The junction between the lateral 1/3 and the medial 2/3 is your point for greater occipital nerve. Again, 3 ml of LA. Take care of the occipital artery here. Okay, repeated aspiration is needed. And here, for the lesser occipital, and now some part of greater auricular also you have to. So a superficial cervical plexus block, again here I have given around 3 ml, which may cover the lesser occipital also. Okay. Now, this was a case of motor area tumor where the same scalp block was given, and with minimal sedation, we could elicit ask the patient to move hands while the surgeon was operating at the motor area, no? And the margins of the tumor could be marked very well. No? See, the patient is complying. She is, and the surgeon is on the tumor. Okay. So now coming to the supraorbital foramen, infraorbital foramen, and the mental foramen. These are the essential landmarks of the anterior skull. Okay, so for LA infiltration in the maxillofacial zone. So an imaginary line passing through all these foramens with the patient looking anteriorly will definitely pass the pupils, through the pupils, if the patient is looking in front. Okay. This is very important when you cannot feel for the foramen. So now, as I had already shown the supraorbital nerve, you feel for the supraorbital foramen, and this is the sensory area, the upper part of your forehead and the bridge of the nose and the medial side of the canthus. Okay. Now, infraorbital, you feel for the infraorbital foramen on the lower orbital ridge. No? So this is a sensory area which includes from the lower eyelid on the side of the nose, the upper lip, the upper incisors, the canines, the premolars, and the root of the first molar. And procedures here you can involve the skin between the lower eyelid and the upper lip, like cleft lip palate, any cystic lesions here or cancerous growth here. You can give an infraorbital nerve this at the infraorbital foramen. Okay, so that was the extraoral approach, and a transoral approach and a transnasal approach is also available. You feel for the lateral, the infraorbital foramen, and especially this is used when you have an infection or swelling of the edema of the face and you cannot feel the foramen from outside. And the bicuspid teeth and the upper border of your maxilla, you feel for the infraorbital foramen, and the needle contacts the bone at the upper rim of and the depth of the penetration should not be more than 2 centimeters. Coming to the mental nerve sensory area is the lower lip, the buccal mucosa, the skin of the chin, but not the lower teeth. Okay, so good for lacerations, the repair of the lower lip and chin. So feel for the mental nerve and foramen and infiltrate along the mental foramen, giving 2 to 3 ml of LA solution. Now this is a fair enough. Keep this picture in mind whenever you go for nerve blocks, because this area is the V1 ophthalmic area, the maxillary area, you can see the nerves covering, and the mandibular area. Okay, and you can see the auriculotemporal nerve also. Okay, so branches of maxillary is what from here. Okay, all the middle meningeal nerve, the pterygopalatine nerve, the nasal branches, that is the palatine nerves, nasopalatine, the greater palatine, the lesser palatine, the pharyngeal branches, zygomatic, cofacial, zygomaticotemporal, the superior, posterior superior alveolar nerve, infraorbital nerve, and all the alveolar nerves. Okay, and outside the cranial wall, the maxillary nerve supplies the sensory branches to the skin of the temple, cheek, the nasal septum, lateral nasal wall, the soft bone palates, upper teeth, and the maxillary sinus in the territory of the infraorbital nerve. So much to remember. So you want the center of the face, anterior face, you have to think of the maxillary nerve block instead of individual nerve blocks. So it's excellent for profound anesthesia in maxilla. The suprazygomatic approach, which I'm showing here, which is the safest and easy, with the patient's head in neutral position. The needle entry point is at the angle formed by the superior edge. This is the superior edge of the zygomatic arch below and the posterior orbital rim forward. Perpendicular to the skin you enter, advance the needle to reach the greater wing of the sphenoid. Okay, greater wing of the sphenoid at a depth of around 1 centimeter or 1.5 centimeters, and then the needle is directed caudad and posteriorly here, okay, to and advanced around 3 to 4 centimeters to reach the pterygopalatine fossa. After negative aspiration, it's a highly vascular area. Give 5 ml of LA. With PNS also, you can give this, you get the temporal muscle contraction or the mandibular contraction also, because mandibular nerve is also very close to this in the pterygopalatine fossa. Now coming to the innervation of the nasal cavity, you can see that the supratrochlear nerve around the bridge of the nose and the infratrochlear nerve comes out, and the ethmoidal nerve. Okay, this is very useful for the steptoplasty. See, anterior ethmoidal nerve enters here, okay, and the posterior ethmoidal nerve, okay, then the infraorbital nerve and the palatine nerves. So nasal anesthesia, what you do is mainly a combination of local anesthesia and infiltration. You can use a topical spray or place cotton pledgets soaked with LA. It blocks the anterior and the posterior ethmoid, sphenopalatine, and nasopalatine. Only if needed, the external nose is anesthetized by blocking the external nasal branch of the anterior ethmoidal nerve, the infraorbital nerve, which is already explained, and the nasopalatine nerves. Now, anterior ethmoidal nerve, you can see the injection is given. Okay, you can use a long needle or a spinal needle is also used. And it's given in the lateral nasal wall anterior to the root of the middle turbinate. Okay, with 23 or a 25 gauge spinal needle, 2 ml of LA is injected in the submucosal area. Now, for septorhinoplasty or FES, is this enough? No, you may have to give the infraorbital nerve block, infratrochlear nerve block along the infraorbital foramen. And sometimes you may have to give a supraorbital and trochlear nerve blocks because you may need to cover the bridge of the nose at the in between both the eyebrows. In addition, this is in addition to the nasal anesthesia explained. Now, coming to the sphenopalatine block. It's a transnasal. You use a spinal needle where this needle is bent at the anteriorly around 45 to 60 degree bend. The superior and the laterally 5 millimeters inferior to the posterior. This is the middle turbinate. Okay. And inferior and posterior end of the middle turbinate. Again, it's a submucosal infiltration of LA into the sphenopalatine foramen. The transoral block is useful when the nose is obstructed with polyps and you cannot enter or there is a lot of infections. So the greater palatine foramen is located posterior and 1 centimeter medial. 1 centimeter, this is the foramen. Okay, 1 centimeter medial to the second and the third maxillary molar. You can palpate the depression with your tongue. If you are giving, you can palpate the depression. It's very typical crater, and use a spinal needle, bend it at an angle of 45 degrees. Around 2 ml of LA solution is injected. Now, this tonsillectomy, traditionally long back, it was done under LA. What nerves are blocked is the tonsil is supplied by 7 nerve fibers. In short, 2 nerve fibers from the middle and the posterior palatine, which supplies the upper part of tonsil. Okay, so you inject at the upper part of the tonsillar pillar to cover the middle and the posterior palatine, and the glossopharyngeal nerve gives 5 branches. Okay, 5 branches, so which is supplying the lower part of the tonsils. You can, at the base of the tonsillar, anterior tonsillar pillar, you can block the glossopharyngeal nerve, and 2 ml of drug is injected by reflecting the tonsillar capsule. The anterior pillar is reflected to block the sensory supply of the lesser palatine and the glossopharyngeal nerve. This completes the all the nerves is blocked for tonsillectomy. Coming to ear surgeries, head, face, neck is not complete without this. The mastoid, tympanoplasty, myringotomy, and foreign body removal are the routine surgeries. Okay, auriculotemporal nerve block, which was already, it's like a ring block, you give 4 quadrant blocks here. The auriculotemporal nerve block, which is already explained in front of the tragus. Okay, it's a branch of the mandibular nerve. The lesser occipital, okay, lesser occipital and the greater auricular, you can cover that at the superficial cervical plexus block, and the nerve block of the auricular branch of the vagus nerve. This is very important, that for pain control following myringotomy and tympanoplasty. The tragus is everted. Okay, and the needle is inserted into the tragus, and 1 ml of LA solution is given. Okay, so this completes the head, face, neck surgeries. This is how I was storing my data and maintaining the standard, monitoring during block, the resuscitation equipments, lipid rescue, and time out, and the site to be blocks. Conclusion is RA as sole anesthetic agent can be done even for head, face, neck surgeries, and RA along with regional anesthesia, along with the general anesthesia, with multimodal anesthesia is the most ideal. Now, coming to the pearls which we have to take care while doing head, face, neck surgeries under sole regional anesthesia is that all resuscitative equipment should be always ready and checked. Monitors should be attached. Proper informed consent and patient cooperation is needed. Vigilant monitoring and communication throughout at each step should be done, because for thyroid and all, if you're using the peanuts, the patient gets very, starts coughing and all. So you have to explain it to the patient very well preemptively. GA should always be ready. It's not RA.
Hello.
Yes, madam, continue.
Hello, can you hear me? Hello.
Yes, madam.
Yes, madam.
Yeah.
Yes, madam.
So there are some small minimal movements, muscle twitches, and the surgeon should be told ki you lift up and dissect the tissues and do not push the tissue over the neck. Separate and powerful suction. In freelancing, we get only one suction machine which the surgeon is using, and during the surgery we cannot share. So you see to it ki you have a separate and powerful suction machine on your side. Can be very difficult with claustrophobic patients. Sedation score to be maintained is just 1 or 2, and the patient should be arousable and communicable. It's contraindicated in heavy bleeding, difficult airway and prolonged duration, and also retrosternal goiters. Lastly, but not the least, intralipid should always be available, because this is highly vascular area, and you can have inadvertent intravascular injection of the local anesthetic agent. Thank you so much.
Wonderful
Thank
session,
you
ma'am.
so much. Yeah. I hope I covered. It is a short time, so I was going fast little.
No, but you covered almost all topics, all blocks of the head neck surgery.
Yeah.
Um,
Any
so
questions?
we move to, can we take question at the end?
Okay, fine. Thank you. Yeah.
Please introduce our next speaker.
Yeah,
I
good
request
evening
chairperson.
all. Yeah. Thank you, Rupali. Good evening all. Before introduction, I'd like to thank ISN Mirrors for today's opportunity. And really, it's a great day to learn from all the experienced faculty. So Mohan Patil sir is not new to me. He's a great anesthetist, freelance anesthetist in Sangli since almost 35 years. Along with his practice, he is very active in IMA, many social and educational
Ganesh, please share
cultural
last slide.
activities.
Previous slide.
Actually, sir's introduction slide I'm not seeing on the screen. Yeah, please. Okay, thank you so much. Yeah. So along with his practice of almost 35 years, he is active in IMA and many social, educational, and cultural activities, sports, trekking. He did many trekking expeditions in Himalayas, camps with Rotary at an international level, and in also Adivasi area of Gadchiroli district for almost last 25 years. He has got a huge experience in pediatric, ENT, and orthopedic anesthesia. Previously, he was attached to Bharati Medical College. At present, he is attached to Prakash Institute of Medical College and Hospital. Over to you, sir, please.
I'm going to share sir screen. Is it visible? Sir, you please start.
Hello? Hello? Am I audible? Am I audible? Am I visible? Hello? Can I start?
You are audible, sir, not visible.
Yes, sir. Yes.
So can I start now?
Yeah, yes, sir.
Lots of thanks for very good introduction by Sudhir. Very good evening to all the delegates, two speakers and chairperson. And I'm extremely thankful to Rupali ma'am and Jadhav ma'am for giving me the opportunity to present whatever I am doing in almost last for 25, 30 years. Should I go ahead? Hello?
Yeah, yes, sir. You can go ahead.
Okay.
We can see your presentation.
And you are audible also very well, very well. Should
Yeah,
I
yes.
increase my voice or this is okay?
This is fine, sir.
Okay. So I am freelance anesthetist as told by Sudhir. So this is my logo. In every presentation, this logo I do present because I am a freelance anesthetist and I have to do lot many works in theater. And as a freelance, I have to do. So I am a surgeon-friendly anesthesiologist. And this is our duty also to help surgeon in all the ways. So my topic given to me is anesthesia for laser ENT surgery or anesthesia for laser surgery as far as ENT cases are concerned. So what is laser? I'm going to have a few slides about the laser because most of this many centers do not have this. Just now I'm talking with Ropali ma'am. Only 2 centers in Sangli are having this laser as far as ENT is concerned. And for ophthalmology and orthopedic, they are having many centers. So what is laser is a light amplification by stimulated emission of radiation. This is for the sake of knowledge. Friends, this presentation I prepared for PG students as there was a lot many times a request to from the seniors in both the institute that our students should know something about laser. So this presentation is done for PG students. So remember one thing, this is a pure practical presentation. I am not a professor or associate professor anywhere. So most of these things will be practical. So is it a newly developing branch? Not at all, because I am giving anesthesia for laser for almost 25 years. So laser is used almost in all medical fraternity. In surgery, diode laser is used for varicose veins, piles, etc., etc. I am talking about ENT laser. CO2 laser is used in ENT. We'll go into the details afterwards. Ophthalmology for diabetic retinopathy, retinal detachment, hemorrhage, etc. In urology, stones, TURP, and bladder tumor where holmium laser is used. Can I go ahead? I want to reply whether I am audible.
Yeah, you're audible, sir.
Okay, thank you. So just now I told you what are types of laser. This is just to complete the presentation. Mainly 2 types of laser. One is beam, second is contact. What we are going to see is CO2 laser is a beam laser, mainly used in ENT cases. And then diode laser is used in vascular or general surgery cases. Holmium laser, I said you, is a contact laser, is used in urology for stones, TURP, bladder tumors, spine surgeries, etc., etc. And for a list of the things, these ophthalmology people and even skin people, they are using. We are not concerned about it right now. So again, this general surgery people, they are using diode laser, is a contact laser, so there is no harm as far as anesthesia or OT persons are concerned. This, so this is diode laser. Laser clinic cannot be completed by buying a single type of laser, but in our area, we don't have too many centers having all the lasers. I don't know how many ENT people they are having, but I was working with Dr. Ashok Puri, who is having ENT clinic in Sangli. So we'll directly come to the CO2 laser. Is a beam laser, is invisible. So as it is invisible, it is dangerous to anesthesiologists, surgeon, and even in OT persons. So as it is invisible, pilot beam acts as a target beam. It is dangerous, can reflect from tissue and even from instruments, so causes harm to eyes and other organs in every person of the OT. So this is one of the older unit. So this is the new unit we were using. On left side, on right side, it is a this thing laser machine. The surgeon is using this scanner, which is again very important, which locates the target beam and at the site laser beam. So this scanner is again very important as far as the machine is concerned. So this is again you can see all the three: CO2 laser, micro. This is also called as a micro manipulator or scanner, and suspension laryngoscope, which is seen there, is again one of the most important equipment as far as laryngeal and these surgeries are concerned. So this is micro manipulator, or can be called as a scanner. It is very important as far as beam and the pilot beam are concerned. So these are some pictures. I think this patient is having tracheostomy. Maybe a case of laryngeal papillomas. See, here are some pictures. The surgeon is using micro manipulator, and anesthesia is given through endotracheal tracheostomy, maybe for laryngeal web or maybe papillomas, warts. So CO2 laser in ENT surgery. CO2 is used because it cuts tissue precisely, seals small vessels and lymphatics, and even ablate small bones also. So emits infrared lights. The beam is totally absorbed by water, and rapid heating is there, which causes vaporization and tissue ablation, and even ablation of small bones. So what are the indications in ENT? Papillomas of larynx, small tumors, laryngeal malignancies, cysts, hemangiomas of larynx, trachea, and bronchial tree, even for tonsillectomy, adenectomy, choroidectomy, and oral cavity lesions like or surgeries like tongue tie, cysts, small growths, and hemangioma. There are a lot many indications. It depends upon the surgeon where he is going to use the laser. So tissue, how laser interacts with the tissue. This is a big sentence, but very important. CO2 laser is absorbed almost completely by intracellular water and causes vaporization of the cells, because 90% of the heat is generated is lost in vapor that is released, cause peripheral tissue injury, necrosis, which is limited to less than 0.1 millimeter. This allows one to preserve laryngeal function, to limit post-operative swelling and pain, and the pathologist to be able to interpret the resected tissue margins. That means the damage caused by CO2 laser is very, very less to the peripheral tissue other than the lesion or whatever it is. So that's why it is a very useful laser. So this is generally the my situation, or whenever I go for surgery, the day prior and till I start the surgery, this is the, of course, this happens with everybody for every surgery. So highlights of anesthesia. This is again very important. as per the site of and size of the lesion, where surgeon is going to operate and what is the size of the lesion, as per surgeon's technique and competency, how surgeon is competent, how fast he is doing the surgery, and what technique he is going to use, whether he is using bronchoscope or which technique he wants. We have to manipulate or we have to modulate our technique according to his technique and his surgical techniques. However, whether tracheostomy is there or not, if tracheostomy is there and if the lesions are supraglottic, it is very easy to give anesthesia. It is like a routine case. Most of the times, TIVA is used, total intravenous anesthesia and jet ventilation. See, friends, for last almost 25 years, I am using this technique only, TIVA with jet ventilation. In short, as per situation, the plan should be modulated or plan should be moldable. One should keep in mind this because we don't know how much time surgeon is going to take, what is the lesion and other many things. Highlights of anesthesia, as I told you, most of the times, see, friends, I am talking about practical things and what I am doing. Theoretical part will be covered by the speakers or in the question answer session. So I'm using total intravenous anesthesia technique. The drug used are propofol, intermediate less time, but most of the time propofol or pentothal, for which syringe pump or drip, propofol drip can be used with relaxant. IPPV is used by jet ventilation using Venturi principle. Here again, there are two types of jet ventilations, which we'll see afterwards. The anesthesia, again, you can use give anesthesia by using small size of endotracheal tube. Jet ventilation can be given through ventilating bronchoscope or through endotracheal tube. Anesthesia can be given when patient is on spontaneous ventilation, but uh, most of the times I am not using this because in spontaneous ventilation, these cords and the lesion is moving. So better to paralyze the patient, whether it is a short-acting or long-acting muscle relaxants. Now, control ventilation, short or long, as I said just now, short or long-acting muscle relaxants as per the duration and technique of the surgeon. Again, anesthesia technique depends on site of the surgery or lesion, supraglottic or infraglottic, available area and space for giving anesthesia, and where surgeon is operating, duration of the surgery. This is most important. Again, the same thing, competency of the surgeon, how expert he is, and whether intubation is possible or not. Whether you are using apneic technique or you are giving Venturi principle, or you are intubating the patient and giving anesthesia through the small size tube. Again, the same thing, you can intubate the patient. If the lesion is small, you can intubate the patient with small size tube. Again, very short lesion is there, short apneic spells can be given, and surgeon can ablate the tissue. Spontaneous ventilation, again, as I said, I am not using because the cords are moving or lesion is moving, which is difficult to target the surgeon, target the lesion for surgeon. Ventilation through bronchoscope or with or without endotracheal tube, I will show you afterwards. This jet ventilation and this high frequency jet ventilation, I am not at all using this. This is just to cover the topic. What I am using is hand operated jet ventilation where Venturi principle is used. Madam, I am able to hear, please. So, as I said, high frequency jet ventilation is a for this specialized ventilator is must. High pressure, low volume is used. Allows good oxygenation or adequate oxygenation and removal of CO2. To be very frank, I am not using this, and even I am not aware of how to use this. So after this is very important. Pre-op glycopyrrolate is must, because if patient is having lot of salivation, it is really troublesome. So adequate atropinization or glycopyrrolate should be given. Then antihypertensives, if a patient is on antihypertensive, should be continued. Additional dose of, I'm using additional doses of beta blocker to prevent raise in blood pressure during and after surgery, for which if patient is fit and if or patient is obese, I'm using atenolol for 2 days. It depends upon the how much is the weight and how much is the BP, 50 or 100 milligram. Clonidine again, it depends upon how expertise you are using in clonidine. 4% halogen spray is a must. It reduces the requirement of anesthetic agents. Again, I'm using Dhylocard intravenously. This prevents cardiac arrhythmias. It, again, 40 to 40, 60, depends upon the weight of the patient. For intubation, for induction, as I said, propofol, etomidate, or pentothal. Etomidate is rarely used. Rarely I'm using, but most of the times propofol is used. For analgesia, fentanyl is the drug of choice. We are getting fentanyl easily, so we are using only fentanyl. No sedative is preferred because we want patient awake, good and awake patient at the end of the surgery. For short procedures or for where lesion is very small, like small papilloma or small cyst of the larynx, intermittent doses, 2 or 3 doses of scoline, and giving apneic technique to the apnea to the surgeon. Surgeon finishes within no time. And if the procedure is prolonged procedure is there, relaxants like hydrochlorium or hydrochlorium can be used. Most important is maintenance of good saturation of 100% saturation of SpO2, which prevents hypertension, bradycardia, tachycardia, and avoid nitrous oxide because at times it can add to the inflammation. It is said better to avoid nitrous oxide. Only oxygen is used. So this is again the situation preoperatively. So for this, because nobody knows what time is surgeon is going to take, what will be the exact his technique, my technique. So you will have to be on the toes all the time. So this is a small video. This actually patient was posted for papilloma, but it turned out to be hemangioma. होत नाही आहे? So these are few pictures. How होते का बघा? So this is in this anesthesia is given by jet ventilation through a small endotracheal tube, which is there inside the this laryngoscope. You can see it properly. So surgeon is injecting local anesthetic if the lesion is well defined. So this is again the Ventura principle is used where this tube is inside the laryngoscope. This is again this is same technique used for maybe I don't know whether the lesion is maybe papilloma or laryngeal web. Is a child of 4-5 years. So this is Ventura is attached to the ventilating port of bronchoscope, rigid bronchoscope, from which you can very well ventilate the patient without causing damage to the lung. The same technique, total intravenous anesthesia with intermittent doses of scoline or completely paralyze the patient with long-acting relaxants using Venturi technique. Jet ventilation through the ventilating port of bronchoscope, rigid bronchoscope. So monitoring as usual, pulse, BP, ECG, NIBP, SpO2, EtCO2, ABG for long duration surgeries, but I am not using arterial blood gas. If something goes wrong in post-operative period, where patient is shifted to medical ICU, then this is mandatory. Temperature monitoring is a routine as far as babies are concerned. And most importantly, safety measures for laser surgery. So what are the problems during anesthesia? Hypertension and tachycardia due to light anesthesia and stimulation of the larynx, because we are dealing with larynx. So preoperatively, beta blockers, and as I said, good analgesia, and depth of anesthesia should be maintained by either with fentanyl and propofol drip, or intermittent. Even you can use intermittent doses of propofol if surgery is of short duration, or you can have syringe pump or propofol drip. The cardiac arrhythmias treated accordingly. Now bronchospasm. Many times it is said that bronchospasm is very common, but as far as I am dealing, very few patients get this bronchospasm. And what is the cause of bronchospasm is fumes. Those are created during ablation of the lesion. Then tumor particles which are likely to go into the bronchial tree. Then light planes of anesthesia. So to prevent all this, pre-op efcorlin 200 milligram and dexamethasone we are using, and treat bronchospasm accordingly. There are again various methods to treat bronchospasm, depends upon when bronchospasm is there, whether it is after the procedure. And most of the times it is after the procedure, because of these fumes and tumor particles which are lying in the bronchial tree, which we are supposed to remove. So all to prevent this 4% Hylucon spray is very, very important. And again, the Hylucard for cardiac arrhythmias. The laser, though a light, should not be taken lightly, as an so an experienced anesthesiologist and surgeon is a must. This is very important. So in this, then this caution should be put on that laser radiation is used. Do not stare into the beam. There are a lot many things which will come next few slides. So you should have good relation with surgeon, because this is a joint venture, and you should cooperate with each other. Then you are going to get success. So precautions while using laser, this is very important. No inflammatory agents should be kept in OT. So these 2-3 slides are very important as far as students are concerned. So which are the inflammatory agents you are not supposed to keep in OT, or you are supposed to keep them out before going for a laser surgery? Is ether, spirit, then alcohol, then mobile. Batteries are likely to get explode if the beam falls on the battery. So mobile should be kept outside, and the equipment having batteries all should be kept outside. Then bucket full of water with mug. It is the mandatory. If something goes wrong and if there is fire, this has to be at hand. Bucket with water with mug. Then special endotracheal tubes designed for laser surgery will come soon. The endotracheal tube should be wrapped. If you don't have special endotracheal tubes, then routine tubes can be wrapped with special material like copper and aluminum foils. This is basic thing. Actually, these two things are very basic as far as laser in ENT is concerned. Then weight gauze piece around the bulb of the endotracheal tube. If you are doing case with endotracheal tube, weight gauze piece should be kept above the this thing, inflated bulb, which will protect the bulb. And secondly, eyes of the patient should be covered with wet pad, and total face should be covered with a wet towel. Literally, patient is covered with, except the oral cavity you can see, rest of the things are well covered to prevent the damage by laser beams, because it is invisible beam, as I told you, and it can cause very much hazards. Precautions while using laser, again, it is controlled. All OT person must wear protective glasses. OT should be well ventilated with exhaust fans, AC, and even routine fans. Turn on laser machine just before the use and turn off immediately after the use, because nobody knows which button is on and which mode of laser is firing. So surgeon should be, anesthetist should tell surgeon that now you can start, and at that time he should turn on his laser machine. This is a aluminum foil. It should not cover this bulb of the endotracheal tube, and there are see, this is a aluminum foil. Even you can use copper foil, which is again very costly. So better to use aluminum, and it is cheap and it is equally effective as compared to the copper foils. Aluminum copper foil is must wrapped around the tube. Copper is the best, but is costly. Aluminum foil equally good and commonly used. Cup should be filled with methylene blue or stained saline to know whether it is intact, and this will tell you that cup is blasted with laser beam. Special material. These are special tubes. Previously, we used to use special tubes, and the cost of the tube is 10,000. And with only one surgery, the tube balloon gets spoiled with the laser beam. So we stopped using, because 10,000 tube in area like Sangli is very difficult to spare for the patient. So best is to use this wrap tube with aluminum foil. So these are the names of the tube. Actually, I have not even seen only one type of tube with the initial period, but after that we stopped using all this. So now laser fire protocol. This is though not common, but you should keep on keep the things ready. If accidentally fire is there, what precautions you are, or what steps you are supposed to take is turn off the laser machine. There is an emergency switch on the machine. You just press it and the machine will stop. Turn all the anesthesia agents and gases. Remove the this wet soap and gauze from the airway, which we usually keep around the tube, if tube is there. Remove endotracheal tube. If fire is there inside, there are chances of getting small parts of the endotracheal tube. And if the patient is paralyzed, get the parts of the tube and endotracheal tube, take it out before putting any other device for ventilation. Pour normal saline in the airway. If fire is there inside, fire extinguisher and water for other victims of the OT. Then how to go ahead? Then once you remove endotracheal tube and part of the tube, ventilate the patient with mask, because patient is already paralyzed. You can easily ventilate the patient. Avoid oxygen if still fire is there, because it helps in combustion. Inspect the tube, whether some part is remaining inside the tree. Do direct laryngoscopy or rigid bronchoscopy if you are suspecting that something is remaining inside. And if the situation is more tragic, do tracheostomy for better ventilation, and of course steroids. Since these well equipped to cope up all for change in surgical technique. That means this is surgeon's job. Patient and OT should be well equipped. Warning notice on OT door. Be aware that laser is on or a red light. And trained OT person should be there. They should help you in these emergency situations. Certain things you are supposed to keep in mind. Hypoventilation causes hypoxia because of small endotracheal tube, for which, and it causes hypercarbia, increasing EtCO2, increased So for this, you just increase tidal volume and respiratory rate, which will get the things to under control. Aspiration of tumor particles. If you suspect any patient is paralyzed with long acting, do suction, remove all particles. Bronchospasm can occur. As I said, it can be treated accordingly. And the most important thing is you are likely to get pneumothorax and pneumoperitoneum because of perforation of the beam or bogey. While many times surgeon dilates the, if there is tracheostonosis or there is a laryngeal wave, many times before putting bronchoscope or laryngoscope, patient many times he dilates uh, the stricture by bogey, which is likely to trachea is likely to get perforated. I come across such two patients in the last 25 years. So you should be aware of laser smoke. 1 gram of tissue is equivalent to 2-3 cigarettes. So you should be cautious that OT should be well ventilated. And this is again very important. Smoke may contain viral DNA and bacterial spores, which like you are likely to get from the environment, and you are likely to it is hazardous. Retroviral contamination has not been proved. HIV, high efficiency mask and smoke evacuators in OT is must to prevent all these complications. Other hazards, venous gas embolism is reported. I never come across this. And vessel perforation, organ perforation, as I said twice, we had this even pneumoperitoneum and pneumothorax also, where it is immediately, we noticed it immediately and treated accordingly with good outcome. Only one incidence of fire I came across where little ether was there, which a small amount, very small, which is not recognizable, was there in ether bottle. Actually, one must see it, and I think we are doing this thing, papillon of the larynx. Fortunately, patient was having tracheostomy, so routine anesthesia was given. Through tracheostomy, small tube was there, and anesthesia continued. And suddenly, blast occurs, and there was actually fire to the this circuit. Fortunately, patient didn't have anything, or this tube was again as it was this aluminum foil was there, tube was safe, but there was a fire to the this circuit, and the blast was so much so large, big that we were not able to hear properly for 3 days. And because of blast of that ether bottle, I had injury to right side of my neck. Again, they were because of this blast of the this thing bottle. Bottle was completely, and all person. The thing was that all myself and surgeon, we both were there. Rest of the this staff, they just ran away, and that is natural also. But we could save the patient, because actually patient didn't have any problem. Only fire was to the circuit, GR circuit. Then chronic injuries to eye, retina, to OT staff. Then this injury to the thyroid and bone, because
मोहन सर ऑडिओ ऐकायला येत नाहीये.
ऑडिओ मे बी नसेलच आता. त्यांनी जस्ट स्लाइड्स दाखवल्या असतील.
हा शक्य आहे. दॅट इज ऑल्सो पॉसिबल. ओके.
सर म्यूट आहेत मॅडम.
बाय मिस्टेक म्यूट झालंय सर आमच्याकडून.
ऑडिओ मे बी नसेलच आता.
पाटील सर म्यूट तुमचं काढा.
त्यांनी जस्ट स्लाइड्स दाखवल्या असतील. ओके ओके.
नाही काय आता बघायचंच आहे फक्त, विशेष काही नाहीये. See, these are religions. So at the end, the big question is always there: who won, surgeon, anesthesiologist, of the patient? So, can you hear me now?
होय होय
Yes.
ऐकायला
Yes, yes, you are audible, sir.
Now, at the end, there is always a question: who won? As we are the person behind the curtain, always our numbers, we are at third place. Patient is first, surgeon is second, because all credit goes to surgeon and we only get inadequate money. Thank you. Thank you for
Thank you very much, sir.
Thank-
Excellent lecture, very informative.
Thank you for
Experience.
patient listening. Actually, we started late, and I don't know. Actually, I told Rupali ma'am that you tell me in between also. You stop your lecture because we are getting late. But I'm extremely thankful to you all for your patient listening. Thank you.
Will you please raise your questions in chat box, or you can ask directly.
I checked for chat box actually. There is no any question in that. But just to conclude, this was really very good session. As an ENT surgeon and anesthesiologist, we will be sharing airway during all these high risk surgeries. So I think we need to have good understanding and need to have a little bit 2-3 minutes preoperative plan has to be sorted out so that things will go easy. So thank you so much.
So one question to Kala madam, sir, please. What type of sedation she gives for all the blocks?
Hello. Yeah,
Hello.
sedation. Generally, see, Fortwin, I don't use fentanyl with regional because the sedation is less with fentanyl. Fortwin and midazolam. I mean, I make a mixture of Fortwin 30 milligrams with 5 milligram midazolam in one syringe, and hardly 1 ml I give. So within 2, that is around 10 milligram of Fortwin and 2 milligrams of midazolam, it should be enough to keep them on score of sedation score of 1 to 2.
Okay, and then how much you tackle the patients with phobia or somewhat psychologically they're one down? Whether
First
you
of all,
choose such-
counseling.
whether you
Yeah,
choose
I
such
discuss
patient for,
without discussion. Yeah.
First, whether you choose such patient for it.
Hello.
Hello.
Yeah.
Whether you choose such patients for regional.
It depends, then it depends on the way the pro and con for whether patients are like, I mean, how much is the comorbidities, Not all patients I'm doing under block. So they are ASA grade 3 or 4. So they are already much counseled by the surgeon by the time they come to me. So they are ready, they tell, they are scared. So little bit sedation before giving block also I can give little sedation. So then they are assured that now she's not going to trouble us a lot.
Yeah. And any experience about nalbuphine, madam?
So far.
See, actually as a freelancer, whatever I'm getting in the area that we use. So sometimes Fortwin is not available. So nalbuphine will do. And I keep Dex kit also ready. Dex kit dextromid with the ketamine mixture, 50-50. Sometimes, as you said, anxious patient or something, so I keep 50-50. So even 1 ml out of that, if the block is very good, they are very, very cooperative.
Yes. Thank you very much, madam. Very elaborate lecture. Very nice.
Thank
Thank
you.
you.
Yes. And you should all start doing these blocks easily with GA, so that you get to be ready for when the patients come for as sole region.
Yeah. We regularly do multimodal analysis here. Even
Yeah.
we do for mastoids, we start with regional. And when we
Huh.
go to middle layer, then we intervene with laryngeal mask and everything. Many a times.
Okay. Yeah.
Thank you. Myself, Dr. Ganesh Lime from Sangli. Thank
Yeah.
you, madam.
Do you come across any last as using so much volume and
Volume has always been within 10 ml, if you had seen.
okay.
Maximum, if it is multiple points, then, but within kept on the lower volume range. Volume is not a problem here.
But it's
Here, the
vascularity.
problem is vascularity.
Hmm.
Yes. So the last, if it occurs, it doesn't give you the typical last. You just have an arrest here. So you have to be very careful. Aspirate every 0.5 ml, and as far as possible, I'm shifted to ropivacaine. Okay, completely. I'm not giving bupivacaine. Last per se is not occurred. Only one case where I was giving trigeminal neuralgia ka block. So so there I had got convulsions which I could control very easily. Just 2 ml of drug.
Okay.
Yeah, but not for surgeries, not the regional. That was way long back, some 20 years back.
Or to control that
encountered.
conversion, what medication have you used?
No, I just deepened the sedation. He came out very easy.
Okay, so with benzodiazepines basically. Or
Yes, yes, yes.
Okay.
It was not even proper convulsions full blown, but I knew some amount, some 0.5 ml has gone intravascular. It's in that very pterygopalatine fossa and all. It's very, highly vascular area. So you have to be, yeah.
Yeah, I have two questions for Kala ma'am. One, in your PPT, it was mentioned that you will mix xylocaine with adrenaline with ropivacaine.
Yeah, yeah, yeah.
Why is it like that? And the second one
Because
is
that is
just
mainly,
comment.
yeah,
Okay.
mainly for this
Okay,
purpose
you
only.
proceed.
Adrenaline I mix with ropivacaine because I should know intravascular. So I
But
keep
why
a
with
watch.
xylocaine?
Yeah, that was become an habit. You can do it
Okay.
only with, yeah. So long back we used to mix adrenaline xylocaine with sensorcaine. So that instead of sensorcaine shifted to, you can do it only with adrenaline and ropivacaine
Yes.
also.
And the second question regarding high maxillary block, because with COVID, actually, we did a lot of maxillectomies under local anesthesia with high maxillary block.
Yeah. Yeah, COVID, we did a lot of surgeries under regional. Yes, sir. Anything else?
Can I answer Dr. Kadam's question, sir? Xylocaine and ropivacaine mixture, because of xylocaine, it acts fast earlier. And after all, it is a mixture, so concentrations becomes a bit less. So we don't need any motor relaxation in head neck surgeries. But lesser concentration, sensory nerves are getting penetrated better. So it is block comes fast and remains for a longer time for a mixture.
Yeah.
Ophthalmic cases also they mix for the same reason.
Okay, sir.
Yeah. Thank you.
Any questions? I want to ask to Khod ma'am. Hello. Ma'am, hello.
इथे आहे मॅडम बरोबर.
Yeah. Ma'am, can you elaborate about video laryngoscope used in laryngotracheal surgery? Which type of video laryngoscopes are better if you want to use? Hello, phone ma'am? No,
Madam
I
is
think
not
she is
there.
not
No.
there.
नाही अनम्यूट करा मॅडम त्यांनी.
Phone ma'am is not on in the meeting right now, I think. No, she is there, but she's muted.
No, madam is not there.
Now, can you hear me?
Yes, ma'am.
Okay. So video laryngoscope has a wider range of application in laryngeal and tracheal surgery. Now, if the airway is difficult because of the subglottic lesions, the type of video laryngoscope you have is one which facilitates the use and angulation the subglottic area and being able to piece and instrumentation also. You can use that as a lower airway assessment even to pass fiber optic or flexometallic instrumentation or jet catheters. So video laryngoscope is not only to visualize but a lower or distal instrumentation. So that's the application, that's the use.
Okay. So routine video laryngoscope or little bit hyperangulated better.
Yeah, routinely it may not be required because the thing is you try to understand the airway difficulty in laryngotracheal. The clinical pictures, measurements, and it is not suggestive or cannot be picked up. So it's not only the visualization that matters. The airway is difficult even lower down subglottic. You understand? And
Yeah, yeah.
the thing that is reduced. So it has definite application, but to instrumentate is much better rather than visualization. That's what is more important. Instrumentation should be possible.
Yeah. Ma'am, my question is there are hyperangulated video laryngoscope or
Yes.
routine Macintosh. So which we would prefer? Hyperangulated or routine Macintosh video laryngoscope?
I would prefer angulated one because the displacement is more anterior in the lesion. Because posterior airway is hardly any support. So it tends to collapse and try to push the lesion more anteriorly. So angulated ones would be preferred. If you are combining and your target is to have a good visualization, better visualization. But for instrumentation, angulation doesn't matter because you got to align and have the flow in the reduced laminar flow.
Okay. Thank you, ma'am.
Thank you.
Shall we conclude or anyone wants to ask?
Any more questions?
No question in
10
chat
वाजले.
box.
Okay. So we conclude here.
Yes.
Is it okay? Usha ma'am and Kadam sir?
Yes. Yes. No
Okay.
questions in chat
Yeah.
box.
Okay. So on the behalf of IC Miras Sangli branch, I am sincerely thankful to our today's eminent speakers for this wonderful presentation and clearing all our doubts and sharing their experiences and also showing different blocks and clearing our doubts and improving our knowledge and making such high risk anesthesia for such high risk ENT cases little easy. Though
Yeah. That's
skillful technique and thorough knowledge is very important. I am also thankful to our chairpersons for making this session interactive and interesting and keeping time for from their busy schedule. I am thankful to SAMS for providing this online platform. I am also thankful to Mr. Ganesh from Genica Technology for providing this uninterrupted digital platform at the same time helping in sharing all the screens and helping to share a screen and all things. I'm also thankful our MMC observer who is our speaker also, Dr. Mohan Patil sir. And thank you all our respected seniors, colleagues students, delegates who have joined for this webinar. Thank you.
Thank you.
Thank you
so
very
much.
much.
Giving-
Thank you
Rupali,
so much.
Thank you.
Rupali,
Thank
one
you.
comment for Dr. Mohan Patil, sir.
What, sir?
Yeah, may listening his all lectures and experience. He is Khatron ka khiladi.
Yes.
That is my nature.
Okay. Thank you, everyone.
Thank
We
you.
Thank you.
conclude
Thank you
this.
so
Rupali.
much.
Yeah,
Thank you and
Thank
good night,
you.
everyone.
Okay.
Good night.
Good night, everyone.
Good
Thank
night.
you.
Thank you and good night, everyone.
Good night, Rupali.
Yeah, good night.
Madam.
हॅलो मॅडम मीटिंग एंड करू का